Okay, so let us finish. Orthopedics. So what we have here is tuberculosis of spine, which is Pott's disease. It is dorsal lumbar region of vertebra. Anatomically, the vertebra develops from scleromes, which are lying either side of the notochord. So each pair of scleromes develop into upper half of one vertebra and lower half of the vertebra above it, and one intervening disc. So it's like this, and blood supply will be supplied by blood supply will occur like this. Blood supply will occur like this. All these three will be one single source of blood supply. Then we have losing the level of vertebral segment by you localize the level of vertebral segment by palpating spinous process. Most prominent at the neck, base of neck is T1. At the level of spine of scapula is D3. Level of lower angle of scapula D7. Floating rib is D12. Level disc D3, D7, D12 is disc. Okay. Level of iliac crest is L4, and level of posterior superior spine is S2. Iliac crest is L4. You need to remember that because you need for lumbar puncture. L3, L4. Posterior superior iliac spine is S2. Then you have cord segment localization. So you can be upper cervical vertebra. You can have cord. You add one to vertebral level. In upper cervical vertebra, you add one to the vertebral level. In upper dorsal vertebra, you add 2 to the vertebral level. Lower dorsal vertebra, you add 3 to the level. At D10, all dorsal segments are over. D12, all lumbar segments are over. L1, all sacral segments are over. Below the L1, cauda equata. So basically, you know that the cord segments will not match the vertebra. So it will be like vertebra will be there and the cord will be there. The cord will end off at L1. L1 is the last point for the cord. Below at L1, all sacral segments are over, and at D2, D12, all lumbar segments are over. D10, all dorsal segments are over. Then cervical vertebra, you add one to the vertebral level because it will become above and below will come like that. You have to remember. Okay, you just add one to the vertebral level. That's it. Add 2, add 3, and next mode of spread: hematogenous spread via paravertebral plexus of vein, which is Batson's plexus of vein is noticed. So types of vertebral tuberculosis: you have paradiscal, central, anterior, and posterior. This image is kind of good. Paradiscal, central, anterior, posterior. So pathologically, bacteria will be lost in the vertebrae, leads to granulomatous inflammation resulting in erosion of vertebrae, compromise in the nutrition to the disc degeneration will occur, vertebral body will be weakened and collapse, wedging or concertina. Wedging may occur, concertina may occur. Then clinical features, you have reticular pain, that is a pain radiating along a nerve root. Depending on the affected nerve root, pain may be in the arm, pain may be in the girdle. Arm is cervical roots, girdle is dorsal roots. Pain may be in the abdomen, dorsal-lumbar roots. Groin pain may be there, which is lumbar roots, and sciatic pain, which is lumbosacral roots. That is reticular pain, developing radiating pain along the nerve root. Stiffness will be there, which is a protective mechanism. Paravertebral muscles go into a spasm to prevent the movement of affected vertebra. Then you also have cold abscess, which is collection of pus and trabecular debris from a diseased vertebra, not associated with usual signs of inflammation like heat, redness, etc. You have paraplegia and you have deformity. Constitutional symptoms will also be there like fever, weight loss, etc. Examination wise, you have gait, which you have short steps in order to avoid jerking the spine. In TB of cervical spine, patient supports his head with both hands under the chin. He will put both of his hands under the chin and will support the head. Then he twists the whole body in order to look sideways. That is indicative of cervical. Paravertebral swelling. Cold abscess may present as fullness or swelling. Tenderness will be there, elicited by pressing the side of the spinous process. Neurological examination, you can find motor, sensory, and reflex examination can be done. Urinary or bowel functions you can examine. Attitude and deformity. TB of cervical spine will be stiff straight neck. TB of lumbar spine will be loss of lumbar lordosis. TB of dorsal spine, you will have kyphotic deformities. So types of kyphotic deformities, you have knuckle, gibbous, angular kyphosis, rounded kyphosis. That is the order. And progressively it keeps on increasing the number of vertebra involved. That's also near kyphotic. Okay. Gait will be the short gait. TB of cervical pain, holding the chin, he'll twist the entire body. Paravertebral swelling, cold abscess may be presenting as fullness or swelling. Tenderness by pressing on the spinous process. Motor and systemic sensory reflex examination. Urinary or bowel functions can be checked. So stiff straight leg, neck is there, loss of lumbar lordosis, kyphotic defects will be there. So types of number of affected vertebra and types of kyphotic deformities: knuckle, gibbous, angular, and rounded. So you can remember it as knuckle, gibbous, angle, round. So radiological examinations, you can have chest and anterior abdomen X-ray for primary focus. Reduction of disc space can be done, and destruction of vertebral body can be noticed in the chest X-ray. Primary focus you have to check. Reduction of disc space you have to check. Destruction of vertebral body you can check. Weakened vertebra may undergo wedging, as you have told before. Rare fraction can be seen. Usual signs: erosion of posterior elements of the pedicle, lamina, etc. can be seen, and erosion of the anterior part of the body can be seen. Then there is evidence of cold abscess. You have paravertebral abscess, wherein there are various types of paravertebral abscess. You have fusiform abscess, tense or globular abscess, retropharyngeal abscess. Behind the eye you can have the abscess. Tense or globular abscess you can have. Below the pharynx you can have the abscess. You can have fusiform abscess, and you can have tense or globular abscess in the paravertebral abscess. Then widening mediastinum abscess formed from the dorsal spine may present as a widened mediastinum. Mediastinum may appear widened. Okay. Retropharyngeal abscess, normally soft tissue in the shadow in front of C3 vertebra, is 4 mm thick. More than 4 mm increases its thickness, indicate retropharyngeal abscess. Soft tissue normally it will form a shadow in front of C3 vertebra. It is 4 thick. More than 4 indicates retropharyngeal abscess. So, as abscess is seen in the dorsolateral spine and lumbar TB. CT scan you can perform wherein you'll find paravertebral abscess, extent of destruction of vertebral body and posterior elements you can notice, and sequestrum or bony ridge may be pressing on the cord. MRI is the investigation of size, type and extent of compression of the cord can be seen, condition of underlying neuronal tissue can be noticed. Myelography can be done, CT guided biopsy can be done. Other general investigations you have ESR, Montauk's test, ELISA for detecting anti-tubercular. What do you say? Anti-tubercular antibodies. Going on, we have differential diagnosis. It can be just back pain like traumatic and secondary myeloma, prolapse, calculating spondylosis. It can be neurological deficit, which is traumatic spinal tumor or secondaries in the spine. It can be. So, treatment you provide anti-tubercular therapy and you take care of the spine. You provide rest to the spine during acute phase and guarded mobilization you have to do. You also have minimum jacket or collar which is immobilizing the cervical spine. Mobilization collar support you have to give for cervical spine and ash brace for dorsal upper spine. So treatment of a cold abscess you have to do aspiration and evacuation. Aspiration is anti-gravity insertion with the needle entering through a zigzag tract you have to do. Evacuation is abscess is drained, the walls are curated. So cold abscess in various parts of the spine you can read up here. First you have cervical spine. You will have a retropharyngeal abscess, and on the sides anteriorly you have retropharyngeal abscess. On the sides you have paravertebral abscess. At the posterior border of the sternocleidomastoid in the posterior triangle of the neck. On the sides you will have a posterior border sternocleidomastoid. In the posterior triangle of neck, trickles downward and enters either of the two lumbocostal arches. So, lateral lumbocostal arch presents as a lumbar abscess. Medial lumbocostal arch present as psoas abscess. Along the musculofacial plane, along two axilla it can be there. Arm along neurovascular bundle of the arm. Along thoracic and spinal nerves to present at anterior chest wall, mid axillary line and posterior chest wall. Okay. Wait, no. Okay, no. Only this much it was there. This is not so. I have not written it properly. Okay. So cervical spine will be there. Retropharyngeal abscess is there. Paravertebral abscess it can be there anteriorly. On the sides, you can have the posterior border of the sternocleidomastoid in the posterior triangle of the neck. Posterior border of sternocleidomastoid, you can find the cold abscess formation. Along the musculofacial plane, you have to the axilla and arm along the neurovascular bundle. It can go to the axilla. So in thoracic spine, you have mediastinal abscess and paravertebral abscess. Again, it trickles down and enters either of the lumbocostal arches. Lateral arch is lumbar abscess. Medial lumbocostal arch is psoas abscess. Along the thoracic spine, it will present at anterior chest wall, mid axillary line, and posterior chest wall. Anywhere you can find cold abscess formation. Then you have lumbar spine. These are prevertebral abscess, paravertebral abscess. Prevertebral abscess, paravertebral abscess. So lumbar abscess or psoas abscess can occur similar to above, and it will be lower, however. Along the neurovascular bundle of the leg, they can present in the groin or down in the leg. And that's it for TB. So TB spine with neurological involvement. You have inflammatory edema. Neural tissue become edematous due to vascular stasis in the adjacent diseased area. You have extradural pus and granulation tissue. Abscess around the vertebra compresses the neural structures. You can also have sequestra, wherein you have devascularized bone and extruded disc material which may be displaced into the canal. that is sequestra, devascularized bone, and extruded disc. Extradural pus and granulation tissue is abscess around the diseased vertebra. Inflammatory edema is neural tissue become edematous due to vascular disease. You also have internal gibbous formation, which is angulation of the diseased spine. Bony ridge formation on the anterior wall of the spinal tract is noticed. Infection of the spinal cord can also be noticed, wherein it leads to blocking of anterior spinal artery. Then you have extradural granuloma. Then types of POTS paraplegia. You have early onset leading to paraplegia occurring in active phase of disease, less than 2 years of onset of disease. It can be due to various causes. You have inflammatory causes and mechanical causes. And inflammatory causes, you have abscess, granulation tissue, circumscribed tuberculous foci, posterior spinal disease, and infective thrombosis of the blood supply. There may be thrombosis of the blood supply, and if that may become infective. Then for mechanical causes, you have sequestrum in the canal may be there, infected degeneration disc can be there, pathological dislocation can be there. So there will be a bone pressing on the cord. That is mechanical causes. Inflammatory causes, mechanical causes. Types of POTS paraplegia. It is TV spine with neurological involvement, whereas this was just TV spine. Neurological involvement is POTS paraplegia. Inflammatory edema, epidural pus, granulation tissue, sequestra, internal gibbous, angulation of the diseased spine, ridge formation on the anterior wall of the spinal cord, infection of the spinal cord, and extradural granuloma. Early onset paraplegia, it will occur in active phase of the disease, less than 2 years. Abscess formation, granulation tissue, circumscribed tuberculous foci will be there, posterior spinal disease, and infective thrombosis of the spinal cord supply. Mechanical causes will be sequestrum in the canal, infected degenerated disc in the canal, and pathological dislocation. A ridge of the bone will be pressing on the cord. Late onset paraplegia is paraplegia after disease has become quiescent. It is more than 2 years after onset of the disease. So it can be a recurrence of the disease, or it can be severe kyphosis. Internal gibbous and fibrous septae forming healing. It can be all those causes. So clinical features, you have muscle weakness, you have paraplegia in extension, paraplegia in flexion, and complete flaccid paraplegia. Muscle weakness, extension, flexion, complete flaccid paralysis. So muscle weakness, spastic and incoordination due to pressure on the corticospinal tract. There is pressure on the corticospinal tract and it will be spastic in nature. Paraplegia in extension, you have tone of muscle involved will be increased due to absence of normal corticospinal inhibition. Normal corticospinal inhibition will be there and the tone of the muscles will be increased. Paraplegia in flexion, it will be due to absence of paraspinal tract function and corticospinal functions. There will be absence of paraspinal tract function and corticospinal functions. Then complete flaccid paralysis, paralysis becomes completely flaccid as well as all transmission across the cord will stop. Then we have grading of POTS paraplegia. You have 1, 2, 3, 4. Okay. Grade 1 patient is unaware. Babinski is however positive, and ankle and patellar clonus will be there. There will be rapid movement upon passive flexion. And grade 2 patient with complaints of clumsiness in coordination. Grade 3 patient is not able to walk only. Paraplegia in extension is there and partial loss of sensation. Patient is unable to walk. Paraplegia in flexion will be there and there will be sphincter disturbances. So investigations, you can perform MRI scan. A type of vertebral destruction can be found out. Presence of paravertebral soft tissue abscess can be found out, and paraplegia also can be found out. So MRI scan you do, type of vertebral destruction, presence of vertebral soft tissue abscess, paraplegia. Type of vertebral destruction: anterior, central, discoid, posterior, paradiscal. Presence of paravertebral soft tissue abscess. Causes of paraplegia, you will have pus or sequestra, etc. So treatment, you can give to conservative treatment, anti-TB chemotherapy, and operative treatment. Operative is paraplegia getting worse with conservative treatment. Paraplegia infection, if it's already there, motor or sensory loss more than 6 months. paraplegia with uncontrolled spasticity, powerful paraplegia, spinal tumor syndrome, and severe quadra equina paralysis. So you can do costico-transversectomy, anterior lateral decompression, radical debridement and arthrodesis, Hong Kong operation, and laminectomy. All of them can be done. Okay, just give me a second. I had to do something. Okay. Okay, so I'll continue after a bit. Yeah.